Then we perform an MRI of the brain and screening of the spinal cord with contrast. There shows mild small diffusion restriction at the left side of the medulla. And spinal cord reveals no abnormality. And the report was suggestive of acute lacunar infarct at pyramid of left half of medulla. Acute lacunar infarct at pyramid of left side of medulla. APS panel, which includes lupus anticoagulant, anticardiolipin antibody and anti-beta-2 GPI, was negative. Then we performed NCS of all 4 limbs. The findings suggestive of are consistent with motor axonal polyneuropathy. And a CSF study was done. It shows color was watery, appearance hazy. There was lymphocytic pleocytosis. Total cell count was 530. Lymphocyte was 67%. Glucose and protein was mildly elevated. Gram stain, AFB stain was negative. This is the brief presentation, examination and investigation findings of these patients. Now we are in dilemma regarding the complete diagnosis of the patients, and from the learned audience we need some light regarding the diagnosis and further evaluation and management of the patient. This is my problem list. Complete diagnosis of the presenting problems, as the patient is SLA with medullary infarct, quadriparesis, impairment of vision, multiple cranial neuropathy, and CSF findings is not interpretation of the CSF findings and the further management.
So I would, you were asking about whether MRA was performed? Okay.
No, MRA was not done. It was our plan, further plan, MRA may be done.
Any suggestion from our learned audience?
In the CSF study, we did not perform gene expert as the patient had no history of fever or no history of any headache, neck pain. So we did not.
Even though the protein is raised, so it gives suspicion of that CNS tuberculosis also. On the background of patient is having immunosuppressive drugs, it should be excluded.
Yes, sir. This could be done, sir. MRI finding was also normal.
But MRI finding doesn't consistent with the finding.
Yes,
it is
sir.
not consistent.
Yes, sir. Yes, sir.
Okay, thank you. Thank you. Very nice comment. So, anybody else from here? Okay.
I'd like to comment about the cranial nerve involved. It could be due to vasculitis, cranial nerve vasculitis from SLE. It can be another explanation about the cranial nerve palsy. And regarding the quadriparesis, I would stick to acute transverse myelitis, because there may be, with time evolution, there may be mixed upper motor and lower motor features, because I think that there was a plantar extensor in one side and there was mixed upper and lower motor features. There may be patient may be at spinal shock at first, then there may be appearance of the upper motor features. And quadriparesis can again explain by brainstem infarction as well, but in that case, retention of urine cannot be explained. So if I make a conclusion of a whole scenario, it could be SLE with acute transverse myelitis with cranial nerve vasculitis at first instance. Okay, thank you.
Okay. Thank you for your nice suggestion.
Thank you, madam. As the patient has no sensory involvement, so transverse myelitis, it will be difficult to explain, and this could be CNS vasculitis or optic neuritis possible. And as the patient had in unilateral optic neuritis is common, but bilateral optic neuritis in SLE may occur, and unilateral optic neuritis in case of retrobulbar optic neuritis, in 2/3 of cases, CSM fundoscopy examination may reveal normal findings. And a phrase told that the patient sees nothing and the doctor sees nothing in case of retrobulbar neuritis. In optic neuritis may be a cause, but quadriparesis with intact sensory transverse myelitis will be difficult to consider as a diagnosis. But if we consider AIDP in case of GBS, in case of AIDP, cranial nerve involvement can also occur.
Okay, let me know another thing. The patient has a pleocytosis, but protein is low. That does not favor GBS. Patient has cell count high. That rather serves some infectious etiology. And again, I somewhat differed with madam. The patient has weakness in lower limbs, but upper jugs are normal in upper limbs, but absent in lower limbs. That cannot also explain a CNS lesion. Lower limb weakness, but upper limbs okay. Jugs diminished in the lower limb, upper limb jugs are, that does not happen something in upper motor neuron lesion. That again brings some other diagnosis, maybe some peripheral neuropathy and CNS involvement overlap, I think. And I had in my mind NMO spectrum, but why should I invite some other diagnosis when I have clear-cut evidence that the patient is having lupus, another autoimmune entity or another entity? So I don't know actually how to explain. And again, APS panel, I think it should be repeated, and if APS comes out again normal, then my diagnosis is neuropsychiatric lupus. Both CNS and PNS involvement is there. Yes. Because lower limbs are weak, so PNS involvement is there.
Yes, sir.
Okay.
Yes, sir. Thank you, sir. Albuminocytological dissociation was not there, so interpretation of CSF finding with GBS will be not likely. But in if we consider two conditions in SLE, both CNS and peripheral nervous system involvement can occur in a sequentially or at one time. So if we consider vasculitis as the cause of cranial neuropathy and peripheral nerve involvement due to AIDP, then we can explain the CSF finding with cranial vasculitis. In case of inflammatory demyelinating polyneuropathy, there will be protein count will be very high, but in case of another variant, that is AMAN or acute motor axonal neuropathy, cell count is less than 50, but protein count that will be mildly elevated, not that much as occurs in inflammatory neuropathy, inflammatory polyneuropathy.
Thank you. Your last comments are very much relevant, and I think that should be, but we should also consider the remote possibilities of multiple sclerosis, MS, that gives the bizarre presentation. And it is not rare also. So we should consider this also.
Yes, sir. The patient had another issue that she had extreme tachycardia, sinus tachycardia, and she was previously normotensive. Now she presented with blood pressure of 130 over 100, and she had retention of urine also. In SLE, there may be autonomic involvement, and in GBS, there may be autonomic involvement. So this may be an explanation of that. Though in GBS, autonomic involvement is not that much common as a presenting feature like urinary retention.
Okay. Okay, so we have very good suggestions and proposals from our learned audience. I think that we can proceed to our experts. So first of all, I would like to take the comments and thinking of Professor Minhaj Rahim Chaudhary, starting from the left side.
Thank you. We usually try to say that the neurologic manifestation is mathematics. So if we can calculate and it will be solved. If we can do it, then it can be solved. But on many occasions, especially in our rheumatology settings, we come across this kind of patients, difficulties, and this way or that way. We can explain and we cannot explain. So here also, already we talked about some conditions, and definitely, again, our learning is common things should come fast. And then again, some rare possibilities also arises when we come across patients. So already we have discussed, and the learned audiences, they have proposed very nicely the possibilities. And definitely we have one condition, the lupus, and lupus have variable presentations. And what the Professor Monwar said, I think the antiphospholipid syndrome, the issue is, antiphospholipid antibodies. Now the issue is whether the titer has been calculated properly. And here it was probably not shown. I don't know, Dr. Riaz showed it or not, 1:40 titer, or if possible 1:80 titer. So, but again, it is negative, we have to keep it in mind. And before telling that one is having antiphospholipid antibody syndrome, the disorder, we have to, ideally we have to examine it after again 12 weeks. So, very unlikely that it could be, we can explain it by antiphospholipid antibody syndrome. However, I think when we cannot make a conclusion, the multiple sclerosis also should come, and she might have, I do agree, if we could explain with one disease, single disease, everything. But here we find difficult situations. And there are points in favor, points against. So I am also in favor to bring another condition like multiple sclerosis with SLE. Possibly we can explain all the features with these two conditions very nicely. Thank you.
Okay. Now I'd like to request Professor Nodhu Isam sir to put his valuable comments on this case.
Good morning, everybody. I think very nice presentation. And then what are the clues here in this presentation? The very pretty unmarried girl, She presented with the acute quadriparesis. Can I say? Quadriparesis. Can you be here? Yes? Yeah. Just supplement me if I miss some of the points. She has tachycardia, she has hypertension, she has urinary retention, and she has the major type of neurological presentation, and then the high CRP, and other findings is the motor axonal polyneuropathy in the background of SLE, and anti-DS DNA is very high. So let's think about how to consider, is it infection or it's by the lupus itself. It's very nicely fit with the lupus itself, and it is the lupus vasculitis. How to that? CRP is very high and she doesn't have fever, nothing else, so push me to consider the lupus vasculitis. Lupus itself, when it is active, it can have the both central and the peripheral effects, and it can produce the motor axonal polyneuropathy, it can produce, and it can also have the multiple nerves there. Disease itself, pathophysiology of lupus itself says the possibilities of your local injury, thrombus formation, and the necrosis. And with all of that, in a short period of time, my diagnosis is the active lupus with lupus vasculitis and all of this peripheral neuropathy. But there are some issues we need to address about the bladder. And the bladder about, already we know, not only the peripheral nerves can be affected, cranial nerves can be affected, and it can affect the autonomic system as well. So with all of that, it's the lupus vasculitis. Thank you.
Thank you, sir, for a nice comment. So next I would request Professor Ashish Mithul, sir, for his comments, valuable comments on this case.
I don't think I have to add anything more than what has been discussed. Just that one clue for me was the sudden onset. So you really, the sudden onset can be only like very few conditions. One is ischemic, one is the vascular event. And pretty much fits into a lupus, CNS lupus, NPSLE spectrum. Couple of tests, because patient is from this region, South Asian region, we have, still I would like to rule out tuberculosis. Because your treatment, you're going to immunosuppress her. And I think the other thing which can cause a multi-system stuff like this is HIV. So that has to be ruled out. Aquaporin for NMO, aquaporin 4 if you have, I think that may be helpful for an NMO, MS kind of a distinction. But your MRI didn't really have much of clues for that. With a high SLEDAI of 26, no doubt that the patient is active lupus, and all these things could be explained by a neuropsychiatric lupus. I certainly go with the comment regarding MRA and MRV, which would have been very helpful in terms of ruling out, because off the top of my head, I can't really remember the causes, but definitely ischemic is something, vasculitic is something which can be ruled out, and of course, repeating APS after 12 weeks. I think that's about it.
Thank you, sir.
Do we have an RBS on her?
Sir, 8.3, sir.
At the time of lumbar puncture?
Sir,
at the time of LP?
Sir, 8.3, sir. 8.3.
Okay, thank you, sir. So then I request Professor Kalimjan, sir, to have his valuable comments. Or
nothing to add actually. The only problem probably what we face, and as you are facing also, is the infection versus the disease. So disease is there, diagnosis is there. You have already said it is a high SLEDAI, very high dsDNA, so it's a high disease activity. Now, what is happening is it a vascular event or is it a, so probably the combination of all, which probably everybody has been discussing, that is the involvement of autonomic nerve that can explain your bladder, the maybe the spinal cord myelitis portion that can explain, and you have imaging which shows infarction. So antiphospholipid antibody, yes, it comes into, so probably the infection versus the lupus and anti-cardiolipin antibody, that comes in mind. Infection, we all know, we daily burn our finger with the tuberculosis, and we always feel, no, it's because of lupus, and suddenly, I was just thinking whether we have seen such a case where we always miss tuberculosis. We were very sure this is a high dsDNA, because we are rheumatologists, it is, our bias is always there towards SLE. But if you ask me, if you visit a medicine department, you will see about almost ratio is, infection is more common than the autoimmunity. So infection has to be taken into account. Of course, it has been said tuberculosis, HIV, both has to be covered. Anti-cardiolipin antibody is a dicey issue because it's a very acute, we have to repeat it after some time. We can't say that it is negative now. So that is the only thing it comes in my mind. Maybe I think, but definitely C has a CNS lupus. What about the antibodies, that anti-ribosomal P-protein or something?
Sir,
those antibodies is specific for the CNS lupus?
Yes, sir. Anti-ribosomal P was not done in this case.
Okay, thanks.
Okay, yeah. Minhas sir, please. Minhas sir.
I have already said that it's very difficult here to explain all the things with one condition. And for example, again, if we bring SLE and vasculitis, so the problem is here again, when we say secondary vasculitis, usually we mean small vessel vasculitis with SLE. And the commonest presentation for small vessel vasculitis is purpura. So these are the things, the points in favor, points against. So I think it's again difficult to explain. But definitely, if we consider some unusual things here, it might be. But again, the issue is the patient doesn't have any evidence of purpura that goes strongly against the secondary one. That's the problem.
So I would like to request the final comment from Professor Galimjan. Professor Galimjan, please. Oh, sir, I agree with all. Okay. Yeah, Professor Ratguru sir, I would like to.
I'm sorry,
No,
I'm
sir,
actually,
I'm
not supposed to speak after the panelist, but even I could not check my temptation. In fact, I have come once in my lifetime, a case of SLE with acute, demyelinating encephalomyeloradiculoneuritis. Of course, in that patient, the MRI features were somewhat present, so it confirmed our diagnosis, and the patient was saved. Sometimes it is called ADEMR, acute demyelinating encephalomyeloradiculitis, but sometimes it may extend up to the peripheral nerves also. There is no abbreviated term in the literature for this condition, acute demyelinating encephalomyeloradiculoneuritis. There is no such recognized abbreviation because the cases are very rare, but it can happen. And also there are reports in literature that ADEM may occur with minimal radiological changes, and that is not rare. ADEM with minimal imaging changes may occur in about 10% cases of ADEM. So I think, and moreover we can see here, there is one lacunar infarct in the left half of pyramid in the medulla, but the plantar was extensor on the right side. So we can say that lacunar infarct should not explain the upper motor neuron signs in the patient. It doesn't correlate. And if we ask about antiphospholipid, that is, I think that should rank low, because actually it was done at the end of approximately 2 months, isn't it? Yes. These investigations. So it is very unlikely that all antiphospholipid antibodies would fail to rise even after 2 months of the onset of illness. If you say, you know, the lymphocytic pleocytosis or albuminocytogenic dissociation, these changes in the CSF actually abates over several weeks. After 8 weeks, they don't persist more often. So, and if we cause vasculitis, vasculitis is usually a focal thing because it causes focal lesions in the brain. And there sometimes it may appear like diffuse when there is extensive vasculitis or many areas are damaged. But the effects of vasculitis are rather more prominent in MRI compared to edema. That is one thing. And also, vasculitis is very unlikely to produce such diffuse changes in the nervous system. So I think we should not forget the possibility of edema-R, lupus edema-R. Thank you very much.
Thank you, sir, for bringing out or lighting out a very uncommon situation to us. Thank you, sir, Atikul Haq, sir. So by these comments, we are closing this first case. Now we'd like to proceed to the second case. I'd like to request Dr. Sharmin Nahar, Phase B resident, Department of Rheumatology of BSMU, to present the second case.
Assalamu alaikum, respected teachers and dear learned audience. Good morning. I am Dr. Sharmin Nahar, resident from Department of Rheumatology, Bangabandhu Sheikh Mujib Medical University. I am going to present a case on a 50-year-old female with digital gangrene and absent pulse. Mrs. X, 50-year-old homemaker hailing from Chatpur, visited to a gynecologist around 10 months back for excessive parvaginal bleeding. She was diagnosed as a case of adenomyosis and endometrial hyperplasia on the basis of clinical feature and suggestive investigation reports, for which surgery was planned. During pre-anesthetic checkup, she was diagnosed diabetic with ischemic heart disease. For further evaluation and management of ischemic heart disease, she underwent coronary angiogram, which revealed normal epicardial coronary arteries. She was put on antiplatelet, beta blocker, lipid lowering, linagliptin metformin combination, and total abdominal hysterectomy with bilateral salpingo-oophorectomy was done around 9 months back. 4 hours after coronary angiogram, she developed fever, which is persisted for last 9 months. Fever was irregular, high grade, highest recorded temperature 103 degree Fahrenheit with chills. There was profuse night sweat associated with anorexia, nausea, significant weight loss, which is not documented by evidenced by loosening of her clothes. There is no cough, hemoptysis, any nodular swelling in any part of her body, any lump, alteration of bowel habit, abdominal pain, joint pain, skin rash, any past history of tuberculosis or contact with smear-positive tuberculosis patient. For this reason, she consulted physician in several occasions and was treated with different type of medication, including paracetamol, without any improvement. Most of the documents are unavailable. As per the available documents, in July 2024, she underwent some investigation which revealed normocytic anemia with neutrophilic leukocytosis and raised ESR. In routine examination of urine, there was 7 to 8 parcel with growth of enterococcus. She was put on oral antibiotic, but there was no significant improvement.
So up to this presentation, so what may be the differentials mimicking in our minds? We began to, so I'd ask from our audible learned audience to have or put some differentials.
First, we must consider the infectious causes that gives rise to prolonged fever of prolonged duration. There is swinging temperature, weight loss, but no definite physical findings except mild anemia. The presentation doesn't give clue to the urinary complaints. However, there is increased pus cell. So, considering the duration and the pattern of fever, and there is enterococci in the culture of the urine. Though it is not usual, but it should be considered. First, urinary tract infection. Next, tuberculosis. It's endemic zone, and the patient is having prolonged fever, and there is no definite clue in any area. Number 3, some periodic fever, but that does not give this same scenario. Though rare possibilities, periodic fever syndrome, the least cause maybe.
Thank you, Dr. Noman Bhai. Anybody else to like any points with him? Okay, Sharmi, you can put. Yeah.
Patient did not give any urinary complaints in her course of illness. There is no urinary complaints.
Excuse me, do I know the weight of the patient, the change of weight during this 9-month periods of time?
Sir, she couldn't mention the exact measurement, but she and her attendant mentioned that there is marked weight loss, and her clothing, there is loosening of clothing, but there is no exact measurement.
And then just is striking to me a continued fever for the 9 months. Is it correct?
Sir, fever was actually irregular. There was few days of febrile period followed by few days of afebrile period. Usually 1, 2 or 3 spikes of temperature in a day. There is no evening rise of temperature. And later on I will show it the temperature chart. We have some differential like tuberculosis, infective endocarditis, any connective tissue diseases or any malignancy. There are some points that goes in favor or against these differentials. Along with fever, 1 month back she developed limb swelling, which was sudden onset, rapidly progressive, initially involving right hand and forearm. 20 days later, it involved both feet and legs, almost simultaneously, associated with severe pain and dusky coloration. In forearm and hand, the swelling was preceded by a sensation of cold and numbness. 2 to 3 days after onset of swelling, she noticed blackening of tip of left great toe. It rapidly involved the tip of other 4 toes of left foot, which was progressive, but there was no discharge or foul smelling. There is no history of any claudication, tingling, numbness, scanty or frothy micturition, Raynaud's phenomenon, dry eye, dry mouth, chest pain, palpitation, shortness of breath, skin injury or infection, similar episode in the past, positive family history or any fetal loss. She is tobacco user in the form of Jorda for last 30 years. She took OCPS for 20 years but stopped it for last 10 years. For that problem, she was hospitalized. Initial evaluation revealed normocytic anemia with neutrophilic leukocytosis and raised inflammatory marker. NA was negative. She was put on oral antibiotic and short-acting insulin along with previous medication. There was no significant improvement. For that reason, she was referred to BSMMU. These examination findings are recorded almost 1 month after onset of limb pain and swelling. On examination, she is normal looking, average body build. Her BMI was 22.87 kg per meter square. She is anemic. Initially, there was bipedal edema that is noted in her document, more marked on the left limb, but during examination, there was no edema. Affected limb skin was dry and there is loss of hair. Photograph showing her both upper limb, hand and forearm. There is gangrene with clear line of demarcation involving all the toes of left foot, mostly confined on the tip. Perigangrenous area appears to be normal in color and temperature. Examination of her peripheral pulses revealed all peripheral pulses are palpable except right radial, right brachial, bilateral anterior tibial, and bilateral arteria dorsalis pedis. There was no bruit. Blood pressure in right arm was non-recordable. In left arm, blood pressure was 110/70 millimeter of mercury. Her respiratory rate was 14 breaths per minute. Photograph showing temperature chart. There is 3 peaks of temperature after her hospitalized period, and highest temperature was 103 degree Fahrenheit, and she is afebrile for last 1 month. Neurological examination revealed pain and touch sensation is diminished in the sole of left foot. There is no lymphadenopathy, organomegaly, lump. Other system examination revealed normal findings.
Dr. Sharmin, just I forgot her age. How old is she?
Sir, 50 years, female.
50?
Yes.
Fine.
Okay,
So
Dr. wants to add something. Okay, please.
Sir, it is a revolving case, and the possibilities goes in favor of vasculitis, as there is losses of pulses and gangrene that fits in favor of polyarteritis nodosa. It is a medium-sized arterial disease. However, it affects both larger size, causing the absence pulse, as well as involving the small size, causing the gangrene also. So, from this, at this point, that is a strong consideration from my part.
Okay, Avushay sir.
Thank you, Dr. Noman, mentioning what is bubbling in my mind also. But this patient having gangrene, right?
Yes, sir.
I need to know onset. How could he develop this gangrene? It is acute onset or gradual onset?
Sir, she mentioned sudden onset. Suddenly, she noticed swelling of her limbs associated with severe pain.
So in this perspective, patient doesn't patient has ANA negative, right? ANA negative, no Raynaud's, no thickening of skin, and no other features of connective tissue diseases. This patient. So one may be thromboembolic, and other things he mentioned. Medium vessel vasculitis. Yes, it could be, but we should check other features like HbA1c positive, weight loss, systemic hypertension. Is there any features of other connective tissue diseases? Other features of polyarteritis nodosa? Could you check this HbA1c positive?
Yes, sir. Yes, sir. I will show it in investigation part, sir. Yes, sir.
Can we think it may be a thromboembolic or embolic? That means hematological, some prothrombotic condition that may causes, you have mentioned is acute onset.
Yes, sir.
So it may be a cause of prothrombotic condition that might have this patient. Should we check this?
Okay, sir.
Dr. Sharmin, Dr. Sharmin.
Yeah, process with Atulok sir. Sir, please.
Now, this patient developed fever following coronary angiogram, right?
Yes, sir.
Can it be, might be due to radio contrast induced vasculitis? Later on the patient developed thromboembolic manifestation. Though in contrast mediated vasculitis there may be leukocytoclastic vasculitis. There should be skin rash, purpura. But sometimes medium vessel or large vessel vasculitis may be caused by radiograph contrast media. Could it be following contrast?
Thank you very much. I rather thank Shamim for shedding light on one very good possibility, but at the same time the patient had fever for 9 months. The thing is that, it started 24 hours after the coronary angiography, and in the scientific literature, there are many case reports of, I would say infectious vasculitis, infectious arterioaortitis, leading to, diminution of the blood pressure in the left upper arm. If blood pressure is different and, pulses are diminished on one side, we should not consider large vessel. Sorry, Numan. We should not consider medium vessel, because medium vessel starts immediately before entry into the organs. Pulses should not be diminished, and blood pressure should not be lower compared to the other side. So, and there are multiple reports of many infectious aortoarteritis, usually caused by Staph aureus, Enterococcus, Salmonella, Pseudomonas, these organisms. And also there are rare reports of, slow organisms or low virulence organisms like Streptococcus, Propionibacterium acne. So actually, I think, in your further analysis, it will become more clear after discussion by panelists, but we should consider infectious arterioaortitis complicating coronary angiography. Thank you very much.
Okay. Thank you, sir, for your valuable
Dr. Sharmin, just to make clear two things to me. Two things would like to clear. You have mentioned limb swelling.
Yes, sir.
Sorry. Upper limb, lower limb, and then can you just enlighten us and elaborate about the swelling with pain, without pain,
yes,
with
sir.
color change, without color change?
Sir, there was pain and color changes, dusky coloration, severe pain and dusky coloration, sir.
Can you elaborate about the limb swelling?
Sir, limb swelling was sudden onset, rapidly progressive, initially involving right forearm and hand, and 20 days later it involved both lower limbs, that is feet and legs, associated with severe pain and dusky coloration.
But now you said probably fever subsided for
Yes,
the last several days, and as well as also the edema subsided.
Yes, sir.
How it happened? Do you have any explanation, like whether she was put on some kind of broad spectrum antibiotics and,
yes, sir.
and also for the reduction of the edema, some diuretics?
Yes, sir. Yes, sir. Later part.
You have applied. Okay, I think.
Right. Yeah.
Sir, I totally agree with Atik sir, but in a different way. Meningococcal infection is very common, and after meningococcemia, a patient having congenital deficiency of protein C might develop these florid manifestation of gangrene. We have encountered few cases in Dhaka Medical College. That is the term purpura fulminans. Purpura fulminans appear as florid gangrene in extremities in a patient with a background of protein C deficiency, and then infection acts as a second hit. So they may experience this gangrene. Actually, these are vasculopathy, thrombus formation due to protein C deficiency triggered by meningococcal infection. So purpura fulminans may be one important diagnosis here. Differential here at least, I think. She has?
No skin rash, no skin.
She has digital gangrene. Only digital gangrene may manifest as purpura fulminans without even involving widespread meningococcal skin rash. I am just explaining this event, and again, with only purpura fulminans, you cannot explain these 9 months fever. So something there is, but this particular event you can assume as a differential purpura fulminans. Okay.
Okay, thank you, Manoj sir, for very...
Sharmin, is she diabetic or? Diabetic?
Sir, diabetic. That was diagnosed during pre-anesthetic checkup 9 months back.
And what's about blood pressure now?
Blood pressure normal.
Okay. I have one possibilities in my mind, because The patient, after having the angiogram, there is a chance of mycotic aneurysm, and that may be a source of emboli, and that could travel different parts of our body. I think we should be careful about this.
And I also agree with Appa that it could be, whether I have a question with the expert, I want to have an expert opinion that whether, is there any chance of cholesterol embolism or not? Because it can be associated with systemic vasculitis sometimes, and patient may present with profound weight loss and profound constitutional symptoms. Since it is after the event of angiogram, so whether it is associated with that. But in the examination and in the investigation, we have to look for the cholesterol, we have to look for the eosinophilic count as well. And I have another question, that what about the urine output for the patient?
Urine output was normal, and the onset of limb swelling was after 9 months of onset of performing coronary angiogram.
Okay. This is definitely vasculitis, but what kind of vasculitis, that is the question. Okay, thank you very much.
Okay, thank you. So I think that you can proceed to the next one.
In complete blood count, there was neutrophilic leukocytosis with persistently raised ESR and thrombocytosis. Highest platelet count was 7.2 lakh. In one episode, hemoglobin was 8.7. That becomes 10.3 after 10 days without any blood loss or blood transfusion. In peripheral blood film, there was normocytic anemia with neutrophilic leukocytosis and later on associated thrombocytosis. In routine examination of urine, there was trace or 1+ proteinuria without any active urinary sediment. CRP was persistently raised, initially 48, later on 27.2. Her other biochemical parameter like serum albumin, ALT, creatinine, serum electrolyte was within normal range. Lipid profile showed only there was triglyceridemia, hemoglobin A1C was raised, iron profile normal. Urine and blood culture sensitivity report revealed no growth. Regarding her immunological profile, ANA on HEP2 cell was negative, rheumatoid factor, anti-CCP, P-ANCA, C-ANCA was below the normal range. Viral marker for hepatitis B, hepatitis C, HIV was negative, VDRL was non-reactive. Regarding her coagulation profile, BT, bleeding time, clotting time, PT was normal, APTT was below the normal reference range, D-dimer was done, one episode which was raised, protein C, proteinase, factor 5 activity, homocysteine, all are with reference range, APL was negative. Regarding her imaging, chest X-ray, 12-lead ECG, color Doppler echocardiography, and ultrasound all are normal. Duplex study of both lower limb revealed. In arterial system, there was mild blood flow was observed in posterior tibial, anterior tibial, and dorsalis pedis arteries of left lower limb, normal blood flow, and in right lower limb. In venous system, there was a old thrombus with signs of recanalization in femoral venous segment. In left lower limb, incompetent saphenofemoral junction, competent saphenopopliteal junction, fissures of chronic venous disease, there was no thrombus or obstruction. Doppler scanning of all 4 limbs was repeat, which revealed increased echogenicity in all the veins of both lower limb, no flow seen in left arteria dorsalis pedis, thrombus in right brachial artery with reduced flow in right radial artery. Comment was distal flow reduction in all 4 limbs, possibly due to increased viscosity of blood. Coagulopathy has to be excluded. CT angiogram of both lower limb revealed normal findings. CT aortogram was also normal. Due to discrepancies between Doppler ultrasonography findings and CT aortogram with CT angiogram, We review the report and comment was also normal. Digital subtraction angiography of both lower limb was done, and impression was left limb angiogram shows abrupt cut of arteria dorsalis pedis at its proximal part just below the level of ankle. Right limb angiogram shows reduced flow at anterior tibial, peroneal artery and gradual tapering of anterior tibial at the level of ankle. Other vessels are apparently normal in caliber and course. Skin biopsy report section shows dermis. It shows mild perivascular inflammatory cell infiltration. No fissures of atherosclerotic plaque are seen. Fissures of vasculitis are not seen either. Now the problem list.
So upon all these findings and investigations, so what are the differences peeping in your mind?
I think many things are clear to us by this time. At least it is not a case of vasculitis. I think it is clear. Though skin biopsy not always exclude the vasculitis, but many imaging, including CT scans, no features of vasculitis, no irregularity and thickening, no other features of vasculitis. And another thing is evident to us, though she has negative APS, right? APS panel
yes,
is
sir.
negative, but there are features of both arterial and venous thrombus. So it is clear, I think, to us, something thrombus, thromboembolic, what may be the cause? Either any patient does have any prothrombotic state or not. We have to search. I don't know. Protein C, protein S is?
Normal range.
Normal. Despite that, thrombus is there, both arterial and venous thrombus, and occlusion. I think it is thromboembolic, and what should be cause? And one thing, this patient having, so far I remember, this patient having long history of OCP. That may be a cause of thromboembolic manifestation, particularly for this patient. Fever, actually, I don't know the pattern of fever. Long history of fever, but no any fever spike of fever, on and off. Really, she does have any fever, I don't know. I am confused here.
Is there urinary complaint?
No, sir.
Urinary infection is one of the cause of fever in case of fever.
Sir, throughout her course of illness, she didn't keep any history of any urinary problems, sir.
Her platelet count is very high. So
yes, sir. 7.2 lakh highest count.
Thank you very much.
Okay. Anybody else? Or?
Thank you. Adding some cause. Is there any possibility of hyperviscosity state? And other cause is diabetic gangrene.
Okay, then, okay, yeah, please, we are running short of time, so one comment from our learned audience.
Actually, Assalamu alaikum. I am Professor Islam Chaudhary from Chittagong. We have came. And can it be cryoglobulinemia? Because other than the feature suggestive of coagulopathy, most of the imaging doesn't reveal solid proof of evidence of medium size vessel vasculitis or other form of vasculitis. It was sorted out.
Cryoglobulin level is not done. Patient didn't give any history of joint pain or any type of skin rash or any neurological feature or any other feature.
Okay. Thank you.
Okay, then we are wrapping up. I think that you can proceed next.
To save her limb without reaching any conclusive diagnosis, after admission she was put on prednisolone 1 milligram per kg body weight along with anticoagulant, that is rivaroxaban 20 milligram along with antibiotic. And in follow-up, after 7 days of treatment initiation, pain and swelling improved significantly, gangrene became non-progressive, and fever subsided after 18 days of hospitalization, and she is afebrile for last 1 month.
So I think that at the time...
Sir, ma'am, 14 days. 14 days.
Okay, so we can proceed towards the opinion from our panel of experts. First of all, I request the opinion from Professor Minaj Rahim Chaudhary, sir.
Okay, thank you. It's a very nice case discussed. And interestingly, so the main problem, already the audiences, they've heard the main presentation like fevers. So it subsided for the last 1 month, important. So what is in my mind really, if again I consider the common things should come first, so one possibility involving the lower limbs, so could it be peripheral arterial disease? That is another one issue. Second is, if it is large vessel vasculitis, sometimes we know patients may have gangrene and possibly she has upper limb claudication also.
No claudication.
No claudication. Yes. Anyway, but the age limit nowadays goes up to some extent, 50 years so. And there are points in favor of definitely peripheral arterial disease because she is diabetic, she is taking Jorda or etc. And so these are the points has to be remembered. And another point also bubbling in my mind, could it be essential thrombocythemia? So if it really persists, because the essential thrombocythemia, the patients may develop thrombus, may develop lymphedema, may develop, gangrene too. So these are the possibilities. I think one bone marrow exam will be justified. Thank you.
Person Odrisam, sir, please.
Thank you. So again, if we look at the clues in this case, sorry. So she is 50 years old, and the heart diagnosis is ischemic heart disease, diabetes mellitus, and with that she has your TG was raised. She was the tobacco user, OCP for the long period of time, and some sorts of history of some limb swellings in this case. And her BMI is normal, and then her gangrene is dry, demarcation is there. Some sorts of pulse deficits in this case, but interestingly, blood pressure is essentially normal. And at the end, you have shown with the combination of medications, some improvement. The treatment says she does have both immunosuppression and the anti-thrombotic treatment. In this case, if I look back, yes, there are some trigger in this case. She had a procedure 9 months back, and then she developed fever. Subsequently, in a period of time, after having several types of antibiotic or by the natural course, her fever gone away. And she have had the gangrene in the distal, in the toes and so and so. So if at the end of the day, if I consider trigger off, so just interestingly, I think if I recall, in 2006 or 7, one report has been published in the American Journal of some journal, and they have reported the CRP positive in this case, CRP positive your peripheral arterial disease. The very interestingly, they have shown this can trigger without having the risk factors of peripheral arterial disease. Someone can present with the features of peripheral arterial disease. What I picked up a trigger, I picked up a dye, and the course of the illness in the background of the your suffering from the gangrene at the end of the day. Diagnosis is peripheral arterial disease triggered by the infection and maybe by the dye as well, and the consequence is the thrombosis. And the outcome of the treatment is for the aspirin and some other things we can add for the improvement. That is, nowadays your RBC pliability drugs are now in use and also in recommendation. So adding of that drug in this case possibly will bring some better outcome. Thank you.
Next person, Matthew sir.
I think I don't have anything much to add, but not in this case, but certainly considering the age, I would just do a malignancy screening because it can be a prothrombotic state, malignancy itself. So I don't think that will be top priority over here, but certainly given the age, I would look at that. And the other thing would be an essential thrombocytosis. I would certainly do a bone marrow. But the good thing is she improved with steroids, so I think we are all happy now.
Okay, thank you. Next person, Bhet Chaturvedi sir.
Yeah, I think everything has been said. Probably it looks like because of age, diabetes, and tobacco, the common things happen commonly. So that is probably, and you have ruled out, it was a good possibility polyarteritis nodosa, but probably female gender, your hepatitis screen negative. So most probably peripheral vascular disease. The only thing is, probably the only thing which I always keep, is it probably the platelet count high is because of the acute phase reactant. That is about what I feel. Because otherwise counts, only just once you had 7,000.
Yes,
The
one
plate, yeah. So probably it is because of acute phase, but yes, the bone marrow can be done if we want to rule out the why fever, because you insisted on fever, and fever was not 1 or 2 days, documented, very well documented fever, and then it subsided. So all along we were thinking about maybe some connective tissue disease, maybe some infection, but since fever is settled down, probably the event, it is related to the event that angiogram and then fever, and maybe something was already lurking inside, and suddenly the gangrene, and the gangrene has a pre-gangrene stage also. So fever is probably because of those ischemic events, because fever can be because of ischemia also. So ischemia, then the whole story is basically an event which is arterial and venous, and vasculopathy, and fever was misleading us. Otherwise, it is a probably more simpler case of peripheral gangrene. You have all the features: age in favor, tobacco chewing, the diabetes, chronicity. You have gangrene and the vessel wall. There is no vessel wall abnormality much in the angiogram. So that is what it comes in my mind. Thank you.
Okay, thank you, sir. Finally, Professor Golimjan. So we have come to the end of the session. So, Atikul Haq sir, would you like to add something else to these comments?
That, I think procalcitonin was not done, isn't it? Yeah, that is one thing. So, since the patient responded to, combination of prednisolone and flucloxacillin, definitely we have to restrict ourselves to, some immune condition or some infection. We are not sure whether it has responded to flucloxacillin or the prednisolone. And of course, in, severe infections, sometimes prednisolone also gives some benefit. So I think, we cannot rule out infection altogether. Thank you very much.
So we have come to the end of the meet of the expert. I would like to express thanks to all the participants, those who have put their valuable comments, and all the panel of experts. Thank you, everybody.
Assalamu alaikum. Good morning, dear participants. Welcome to the session of rheumatoid arthritis. This session will be moderated by Major Dr. Khundokar Mahbub-ud-Zaman. I like to request Mahbub-ud-Zaman to conduct the session. Mahbub, please.
Good morning, dear audience. I welcome you all to today's first session on rheumatoid arthritis. Rheumatoid arthritis is a chronic rheumatic condition with a prevalence of 0.5 to 1% worldwide. So today we'll talk, we have discussion on this topic. For this discussion, we have two speakers, one from home and one from abroad. Dr. Ziaul Haidar will be speaking from home, and Professor Gelimzan, he's from Kazakhstan, he will also talk. I have two chairpersons for this session, Professor Ismail Patwari sir and Professor Syed Manu Ali sir. They will chair this session. So may I ask both the chairpersons to come on dais to take their chair. Thank you, sir. Now, I would like to call two of the today's speakers to take their chair over this dais. Professor Gelimzan from Kazakhstan and Dr. Muhammad Ziaul Haidar from Bangladesh. So the first speaker will be Dr. Muhammad Ziaul Haidar. He graduated from Chittagong Medical College. Then he obtained his MD in rheumatology from Bangabandhu Sheikh Mujib Medical University. Now he has been working as an assistant professor of rheumatology in Rajshahi Medical College Hospital. He will talk on keeping eye on heart, optimize the management of rheumatoid arthritis. May I ask him to start his talk?
Bismillahirrahmanirrahim, the most gracious and the most merciful. Thank you, Dr. Mahbub, for your kind words. Honorable chairpersons and respected audience, Assalamu alaikum. Today I will talk on keeping an eye on the heart optimizes the management of rheumatoid arthritis. We know that rheumatoid arthritis is an autoimmune chronic inflammatory disease. The incidence of this disease is 0.5 to 1% of the population. It increases with the incidence increases with the age. The peak age is 35 to 50 years. Women are more affected. Among other extraarticular manifestations, cardiac manifestations are very common. I will talk on the cardiovascular risk of rheumatoid arthritis. What are the risks of incidence of cardiovascular diseases in rheumatoid arthritis? In a meta-analysis, 14 studies were studied among 41,490 patients. The overall cardiovascular disease risk was increased by 48%, and the risk of myocardial infarction was increased by 68%. Risk of cardiovascular accident was increased by 41%, and the risk of congestive heart failure was assessed in 1 studies, and the risk ratio was 1.87. The risk of unrecognized myocardial infarction and sudden death are also increased in rheumatoid arthritis. The risk ratio of unrecognized myocardial infarction rate was in a study was 2.13, and the sudden death was 1.94. The risk of congestive cardiac failure in rheumatoid arthritis. In the Rochester cohort, the risk of congestive heart failure was increased 34% after 30 years follow-up compared to the non-RA patients. Even after the adjustment of cardiovascular risk, the risk was twice compared to the non-RA patient. Risk of premature atherosclerosis was also increased in rheumatoid arthritis. In a cross-sectional study of 98 rheumatoid arthritis patients with match control evaluated, the atherosclerotic plaque was 3 times higher than compare group, and the adjusted predicted prevalence was 38.5% for rheumatoid arthritis versus 7.4% for the control group. Dear audience, we know there are several risk factors for rheumatoid arthritis. Inflammation is the key role player in the pathogenesis of rheumatoid arthritis. Here, marker of chronic inflammation is the modifiable risk factor that is very much important for the management of rheumatoid arthritis and cardiovascular risk. What are the traditional risk factors in rheumatoid arthritis? In a meta-analysis, in 15 case control studies, 2,956 patients and 3,713 controls are studied. They are smoking, diabetes, and low HDL are the prevalent in rheumatoid arthritis patients. In the same meta-analysis, hypertension was the same prevalent. Usually hypertension are undiagnosed and untreated in patients with rheumatoid arthritis. Rheumatoid arthritis equals the diabetes mellitus as an independent risk factor for cardiovascular disease. In a 3-year study shows the RA equivalent the diabetes mellitus as an independent risk factors. Physical activities in rheumatoid arthritis reduced compared to the control match for age and sex. Pain, stiffness, poor mobility, rest taken by the patient themselves or sometimes advised by the physician are the causes of this inactivity. Dear audience, we know there is association of higher mobility of BMI with higher mortality. But in case of rheumatoid arthritis, BMI paradox the effect. Here, low BMI is associated with higher mortality and high BMI is associated with lower mortality. This low BMI mainly associated with higher inflammation, active inflammation. Lipid paradox in the rheumatoid arthritis. Low LDL, HDL, and total cholesterol levels are inversely related to the disease activity. Low total cholesterol and LDL during higher disease activity. This level increases with the reduction of the inflammations. Although in patients with rheumatoid arthritis, low level of LDL and total cholesterol, they have higher cardiovascular risk. So total cholesterol HDL ratio might be the useful marker for the monitoring of cardiovascular risk in the rheumatoid arthritis. Effects of rheumatoid arthritis on HDLs. Anti-inflammatory and anti-atheroprotective characteristics of HDL is changed to pro-inflammatory and atherogenetic characteristics. And the inflammatory marker, especially CRP, has inverse relationship between. If you see here, there is increase CRP during inflammation, even after it may occur after surgery or myocardial infarction, and lipid becomes lower. But after inflammation, level of inflammatory marker is subsided and lipid become normal. CRP independent predictor for the cardiovascular death in rheumatoid arthritis. And there is hazard ratio was 3.3. Effects of conventional DMRs on cardiovascular risk on rheumatoid arthritis. Patients of rheumatoid arthritis who used methotrexate, sulfasalazine or hydroxychloroquine had low cardiovascular risk, and the patient who used hydroxychloroquine, their lipid level was improved significantly. What is the effects of JAK inhibitor on cardiovascular risk in rheumatoid arthritis? In a study shown that JAK inhibitor may not increase the risk of major adverse cardiovascular events in rheumatoid arthritis, but it is associated with a higher risk of all causes of mortality compared to adalimumab. So, during prescription of JAK inhibitor, particularly tofacitinib, consideration of risk of cardiovascular disease should be taken in mind. Effects of JAK inhibitor on cardiovascular risk in rheumatoid arthritis. Another study shows no significant changes in cardiovascular risk for JAK inhibitor treated patient with rheumatoid arthritis. It increased the risk of thromboembolic events for both tofacitinib and baricitinib at higher doses. TNF significantly reduces the cardiovascular events, including myocardial infarction, congestive cardiac failure, and stroke. Effects of tocilizumab on cardiovascular risk in rheumatoid arthritis. In a meta-analysis, 19 studies along with 11 RCTs and 8 cohorts shown that despite increase of cholesterol level, tocilizumab has safe cardiovascular outcome compared to other biological DMRs. Effects of rituximab on cardiovascular risk on rheumatoid arthritis. It suppresses systemic inflammation, improves lipid profile, decreases the atherogenicity index, increases carotid intima media thickness, ameliorates elastic properties of the arterial wall. What is the pathogenesis of cardiovascular risk in rheumatoid arthritis? Mainly inflammation plays the key role in the disease process along with traditional risk factors. If we see this picture, in synovial inflammation there is increase of cytokines, decreased nitric oxide, decreased IL-10, increased matrix degradation product, and as a result endothelial dysfunction, altered blood lipid profile, atherosclerosis, thrombus formation, ultimately increased cardiovascular diseases. Cardiovascular mortality in rheumatoid arthritis. In 24 studies in a meta-analysis shown that 1,11,758 patients with 22,927 cardiovascular events are analyzed, and overall mortality risk was increased by 50% in rheumatoid arthritis patient. The mortality of risk of ischemic heart disease increased by 59%, and the cardiovascular accident increased by 52%. But, the dear audience, it is hope for us that trends of cardiovascular mortality in rheumatoid arthritis reduced after 2003 due to modern treatment strategy. Learned audience, now what are the tools for the cardiovascular risk assessment in rheumatoid arthritis. There are several tools: Framingham score, systemic coronary risk evaluation, atherosclerotic cardiovascular disease risk estimator plus, Q-DISC-3, expanded risk score rheumatoid arthritis, Reynolds risk score, Euler recommended methods for the cardiovascular risk assessment, and carotid ultrasound beam imaging, artificial intelligence-based technologies. This is Framingham risk score. It can be done online. If you input these informations, it can be classified in high, intermediate risk, and low risk. These are the screenshots of mobile apps showing the estimator used by atherosclerotic cardiovascular disease ASCVD risk estimator plus. If we input age, sex, blood pressure, cholesterol level, smoking status, then we will get 10-year cardiovascular risk, and it can be classified into low risk, borderline risk, intermediate risk, and high risk. Systemic coronary risk evaluation score. It is applied for the Europeans, and it can also be classified very high risk, moderate risk, low risk. Dear audience, now we can calculate here, for an example, a patient with 65 years, man, smoker, has systolic pressure of 120 and cholesterol level was 6. So the risk will be 12, and it goes to a very high risk group. Euler recommended for the cardiovascular risk assessment for rheumatoid arthritis. Euler recommended score into 1.5 when the disease duration is more than 10 years of rheumatoid arthritis, positive rheumatoid factor, NTCCP, and extra-articular symptoms. Q-DISC-3, it also can be calculated from online. It is validated to quantify absolute cardiovascular risk. It included age 25 to 85. It includes rheumatoid arthritis, SLE, glucocorticoid use, no need to multiply with 1.5. Expanded risk score in rheumatoid arthritis. Performance of this expanded cardiovascular risk predictor score of rheumatoid arthritis is not superior to the American College of Cardiology and ASA risk calculator, that is ASCVD risk. And its performance of ERS-RA was not better than that ACC-HA into 1.5, and also didn't perform well in high inflammatory patients. Reynolds risk score for cardiovascular also can be calculated from online. Carotid ultrasound beam imaging, it is non-invasive, economical technique, superior performance compared with conventional calculators, and the accuracy of risk assessment can be improved using artificial intelligence technique. Artificial intelligence technique in cardiovascular risk assessment. It is not used to assess cardiovascular risk and rheumatoid arthritis patient, but it used to assess cardiovascular disease risk assessment in non-rheumatoid arthritis populations. Better performance in compared with conventional risk calculators. Artificial intelligence, that is AI-based cardiovascular risk assessment in rheumatoid arthritis, can be made possible by combining several types of risk assessment: patients' demographics, physiological parameters, behavioral risk factors, image-based phenotypes, rheumatoid arthritis, with combining machine learning system and deep learning system, and it can be classified into low atherosclerotic cardiovascular disk and high atherosclerotic cardiovascular disk. Dear audience, now the management of cardiovascular risk in rheumatoid arthritis. Mainly two components: tight control of inflammation and rheumatoid arthritis disease activity. Here we can follow the Euler criteria for recommendation, that is low disease activity or remission, with traditional control of cardiovascular diseases. Role of statin in reduced cardiovascular risk in rheumatoid arthritis. In Jupiter trial, it's shown that rosuvastatin 20 milligram significantly reduces the major cardiovascular events. In Jupiter trial, the primary endpoints are non-fatal myocardial infarction, non-fatal stroke, unstable angina, arterial revascularization, cardiovascular death, and the risk was reduced 44% with use of rosuvastatin. American Heart Association and American College of Cardiology recommended for statin therapy for cardiovascular disease. LDL more than 190, age 20 to 75 years, high intensity statin therapy, who target more than 50% of reduction and goal less than 100. Diabetes with LDL more than 70, age 40 to 70, moderate intensity statin therapy. And high risk group, LDL more than 70, age 40 to 75, high statin therapy and target go more than 50% reduction of LDL. Intermediate risk, LDL more than 70, age range 40 to 75 years, moderate statin therapy, and goal of LDL more than 30% reduction of LDL. We know high intensity statin therapy means commonly used in our country, atorvastatin 40 to 80 milligram and rosuvastatin 20 to 40 milligram, and moderate intensity statin, atorvastatin 10 to 20 and rosuvastatin 5 to 10 milligram. EULAR recommendations for the cardiovascular risk management in rheumatoid arthritis. Clinicians should be aware of the higher risk of the cardiovascular diseases. The rheumatologists are the responsible for the cardiovascular risk management. NSAIDs and corticosteroids should be prescribed according to the recommendation from EULAR and ASAS. Disease activity should be controlled optimally. Cardiovascular risk assessment should be done once every year and following major changes in anti-inflammatory therapy. Cardiovascular risk estimation should be done according to national guideline. If there is no national guideline, SCORE CBD model can be followed. Total cholesterol and HDL can be used in CVD risk assessment in rheumatoid arthritis. Cardiovascular risk adapted 1.5 multiplicator factor, as I mentioned earlier. Screening for asymptomatic atherosclerotic plaque by use of carotid ultrasound. Lifestyle modification includes healthy diet, regular exercise, and smoking cessation. Cardiovascular risk management should be followed according to national guidelines like hypertension and statin therapy. NSAID should be used with caution, especially patients with documented cardiovascular disease and presence of cardiovascular risk factor. Glucocorticoid should be used in minimum doses, and glucocorticoid should be tapered in case of remission or low disease activity. Reasons to continue glucocorticoid therapy should be checked regularly. Take-home messages. Cardiovascular risk is 1.5 times higher in rheumatoid arthritis than general population. Cardiovascular risk should be assessed with a validated tool. Aggressive management of traditional risk factors and optimization of anti-inflammatory and immunomodulatory therapy as the main role for management of rheumatoid arthritis and cardiovascular risk in rheumatoid arthritis. Statin should be prescribed in intermediate or higher risk group. NSAID should be used with caution in patients with rheumatoid arthritis and cardiovascular disease. Glucocorticoid should be used in minimum effective doses with shortest possible time. Regarding DMRs, conventional DMRs like methotrexate, sulfasalazine, and hydroxychloroquine and biological DMRs are beneficial. But during use of JAK inhibitor, caution should be taken. Thank you very much for your patient hearing.
Thank you, Dr. Mohammad Ziaul Haidar, for nice deliberation on cardiovascular risk assessment and its management in rheumatoid arthritis. We should remain vigilant to assess the risk of cardiovascular morbidity in rheumatoid arthritis. Moving on to next speaker. Our next speaker is from Kazakhstan, Professor Togizbayez Galimzan Aselbegovic. He is a chief rheumatologist of Ministry of Healthcare of Republic of Kazakhstan. He graduated from Aktob State Medical Academy in 1997 and did PhD in Asfenidayadev, Kazakh National Medical University. After this, he worked as head of Internal Diseases Department in Research Institute of Cardiology and Internal Diseases until 2005. Later on, he was leading the Rheumatology course in Almaty Institute for Advanced Medical Education and was the rector for the institute in 2013 to 2016. Now he has been working as chairman of Kazakh College of Rheumatologists, the rector of Almaty State Institute for Advanced Training for Doctors, and the chairman of the board of Kazakh Medical University. So let me take the privilege to welcome him to deliver his speech on use of olokizumab in rheumatoid arthritis in real life experience and the offline use of IL-6 inhibitors in rheumatoid arthritis. Please, thank you.
Dear colleagues, dear chair participants, welcome you all in this RA management session. Thank you for this opportunity. In my presentation, I wanted to share, where is this? Next. Yeah, thank you. I wanted to share both current experience with IL-6 inhibitors in medicine overall and rheumatology, and to point out our own practice with use of one of the IL-6 inhibitor, olokizumab, in patients with rheumatoid arthritis. The main problem that the rheumatologist faces when it comes to initiate biologics is which one of choose. Actual clinical guidelines, both EULAR and ACR, proclaim that generally all biologics and JAK inhibitors have pretty much the same efficacy and tolerability, and so the choice of treatment is generally individual and based on patient profile. However, one point is very important. When we start new treatment, we want to be effective and safe for the patient for as long as possible. Moreover, this 14-year retrospective observation shows that both for bio-naive patients and for those who switched from other biologic therapy, the retention, the number of patients who remained on treatment after some time, in this case, 6 years is higher for IL-6 inhibitors in comparison to TNF inhibitors and abatacept. Therefore, when we start this treatment, we can expect longer stability of patients' health. What idea lies behind the using of IL-6 inhibitors in the first place? And in addition, what is IL-6 is the first place? IL-6, a polypeptide, it's produced by numerous different cell types and plays a critical role in regulating the acute phase response, hematopoiesis, inflammation, metabolic control, liver regeneration, bone metabolism, and cancer progression. IL-6 induces the production of acute phase proteins such as C protein, reactive protein, fibrinogen, serum amyloid A, and hepcidin, which can reduce albumin synthesis in hepatocytes. High levels bone marrow, IL-6 induce megakaryocyte maturation into platelets and promotes hematopoietic stem cell activation. In addition, IL-6 promotes differentiation of osteoclasts and angiogenesis, proliferation of keratocystis and mesangial cells and growth to myeloma and plastocytoma cells. Let us look at the discovery and development of IL-6 inhibitors. This timeline shows progress in the field of IL-6 pathway inhibition following the initial identification of B-cell stimulation factor in 1973 and the more definitive biochemical and molecular studies carried out in the 1980s and 1990s. To clinical trials and approval in various diseases in the 2000s and up to present day, we can see that the development path for an IL-6 inhibitors for the treatment of RA, the most common chronic autoimmune disorder that primarily affects joints, began in the early 1990s. It's important to point out the recent approval of interleukin-6 inhibitors in COVID-19 pneumonia and the recent appearance of new subclass of direct IL-6 inhibitors affecting IL-6 itself. Such a complex mechanism of action defines the possibility to affect IL-6 via inhibition its signal pathway in various disorders. As IL-6 has multiple roles in the dysfunction of the immune and the inflammatory system, anti-IL-6 receptor therapy could relieve various symptoms such as fever, fatigue, pain, joint destruction, and anemia and other. Thus, we can differentiate it using IL-6 inhibitors in joint disease, where several drugs were approved for rheumatoid arthritis, juvenile idiopathic arthritis, and adult onset Still's disease. As you know, the ability of tocilizumab, sarilumab, and olokizumab to improve to clinical signs and symptoms as well as quality of patient's life and laboratory parameters was shown in numerous clinical trials, even when monotherapy was used. Speaking about juvenile idiopathic arthritis, we should point out the difference between systemic and the polyarticular forms. Systemic GI was associated with overproduction of IL-6, which explains most clinical features of disease. Subsequent trials confirmed extensive improvements in the signs and symptoms of disease following treatment and clinically relevant glucocorticoid sparing potential of IL-6 inhibition. The approval for polyarticular juvenile arthritis came later. Let us switch to some other rheumatic disease. IL-6 concentrations are elevated in serum and urine samples from patients with SLE or lupus nephritis and correlate with disease activity, while in the initial phase 1 trial, tocilizumab improved disease activity, specifically arthritis, and reduced the level of antibodies to double standard DNA. This was not proven in later trials with sarilumab. Therefore, the question about efficacy of IL-6 inhibitors in SLE remains unanswered. Phase 3 trial with tocilizumab was performed in patients with systemic sclerosis, but although it showing numeral reduction in skin score in comparison with placebo, and while improvements in skin thickening were not statistically significant, tocilizumab performed better regarding forced vital capacity of the lungs. IL-6 was also implicated as an important factor in the pathogenesis of both giant cell arthritis and Takayasu arthritis in the 1990s. Serum level of IL-6 correlated with disease activity in both diseases, and IL-6 inhibitors improve disease signs and symptoms in patients with refractory GCA or refractory Takayasu arthritis in time to relapse during glucocorticoid tapering in Takayasu arthritis was proven in clinical trials. Tocilizumab was approved for giant cell arthritis and for Takayasu only in Japan. I should also mention that since 2020, IL-6 inhibitors, tocilizumab and olokizumab, were evaluated for COVID-19 associated pneumonia. Based on the data, tocilizumab reduced all-cause mortality in all studies and reduced mechanical ventilation and length to stay in RCTs in hospitalized COVID-19 patients. Olokizumab in patients with mild to moderate COVID-19 with several risk factors for the severe course is as effective a method of preemptive anti-inflammatory therapy as the use of Janus kinase inhibitors, but stronger suppression of markers and symptoms of intoxication. So, IL-6 targeting therapy has been shown to be effective in various chronic inflammatory diseases as well as in pathological conditions caused by autoantibodies or pathological conditions accompanied by fibrosis. There are many case reports in which IL-6 inhibition was effective, but sometimes further confirmation through clinical trials is required. The understanding of the characteristic cellular, molecular, and gene expression changes in the immune system that are significantly changed by IL-6 inhibition is improving. Different IL-6 pathway inhibitors affect various sites. IL-6 receptor inhibitors like tocilizumab and sarilumab act as the site 1 of the receptor, and non-approved saricumab and clazakizumab attack the same site on the site of ligand. Here, the IL-6 receptor is attached to IL-6 molecule during the formation of trimer complex. At the same time, olokizumab acts at the final hexamer formation. This difference in mechanism of action determines the different effects of the drugs. First, briefly about the product itself. It's a direct IL-6 inhibitor, which alternatively to other currently registered for rheumatoid arthritis products, sarilumab and tocilizumab, affects directly then the IL-6 molecule and not the receptor, and selectively blocks the final assembly of the signaling complex. It's a solution for subcutaneous injections and can be used once every 4 weeks or once every 2 weeks. The relatively rare injections are determined by long half-life that is about 31 days. Olokizumab is currently registered in some countries and in Kazakhstan. Since most frequently used IL-6 inhibitor is tocilizumab, we have to define the place of these two products in treatment of patients with RA. We can presume that due to the mechanism of action, while on tocilizumab, IL-6 concentration goes up. In patient on olokizumab, concentration of IL-6 will be reduced. However, this is not yet proven. Another aspect I wanted to point out is the relatively different dosing regime. With tocilizumab, you can go every 4 weeks only if you use intravenous form, but with subcut should be once every week. Olokizumab can be used every 2 weeks or every 4 weeks. We should say that most of the frequent adverse events indicated in the label are class-specific and similar in tocilizumab and olokizumab. Most often, we see laboratory abnormalities like transaminase and lipids increase, local site reactions, cytopenias, and infections. Although there were very few cases of gut perforations in patients with diverticulitis, we should pay special attention to the state of gut in these patients. As I said before, meta-analysis is one of the key methods of comparing safety and efficacy results. Recently, a number of articles including data on IL-6 inhibitors was published, and for example, meta-analysis by Lee and all showed that based on all key clinical trials, while tocilizumab patients had few number of withdrawals, patients on olokizumab had generally few serious adverse events. When we compare the efficacy of the two products, we can use either the results of head-to-head comparison trials or meta-analysis. In phase 2b study, several doses of olokizumab were compared with tocilizumab intravenously in patients with insufficient response to TNF inhibitors. After 12 weeks, authors evaluated various efficacy parameters, including the DAS28 that we also evaluated in our study. We see here that DAS28 remission was from 10 to 25% in different dosage, and the difference between olokizumab once every 2 weeks, olokizumab once every 4 weeks, and tocilizumab was insignificant. The result of phase 2b trials of olokizumab were confirmed in large-scale CREDO program of phase 3 studies, which were done in 19 countries and included more than 2,400 patients, both biologic naive and those with inadequate response to TNF inhibitors. Unfortunately, due to limited time, I cannot show all the data of this trial, but I will focus on our own open-label prospective data. In this observational clinical trial, we were intended to evaluate the efficacy and safety of olokizumab in RA patients, a real-life experience. Patients of both genders aged more than 18 years were enrolled using ACR diagnostic criteria of rheumatoid arthritis. Those who were suffering from infection, fructose intolerability, and wishing to become pregnant were excluded. In this single-center clinical trial, 26 patients were enrolled. Out of them, 19 completed 4 weeks and 9 completed 12 weeks. 1 patient was excluded for switching to another biologics. In addition, 1 patient was withdrawn for lack of efficacy after 3 months. Thus, 28 ECR and PGA were the disease activity assessment tools. Results analysis was done on 24 patients. Around 90% patients were female and mean age was 52 years. The mean disease duration was 7.8 years. All of them were seropositive, and X-ray-based erosive arthritis was in 52% patients. High and moderate disease activity was in 73% and 27% respectively. 55% of enrolled patients received corticosteroids. Dose was 2 to 32 milligrams. All of them were on subcutaneous methotrexate. 74% patients were biologic naive. Mean reduction of DAS28 is SR 2.93 at 1 month in 19 patients. Further reduction to 2.22 at 3 months in 9 patients. In 1 month period of follow-up, corticosteroids were withdrawn in all 15 patients who initially received them. High activity was identified as DAS28 more 5.1. Moderate activity was established in patients with DAS28 from 3.2 to 5.1, and low activity was considered in patients with DAS28 below 3.2. Of 7 of 9 patients achieved low disease activity of remission within 3 months of therapy start. Adverse events included, as you see at these slides, cholecystitis, blepharoedema, aggravation of the existing allergic dermatitis, mild raised AST and ALT, aggravation of joint pain was observed in 5 patients only. So, in conclusion, phase 2B clinical trials here shown the similar efficacy of olukizumab and tocilizumab in multiple endpoints. Olukizumab in combination with methotrexate was generally safe and well tolerated in the treatment of patients with rheumatoid arthritis. In our trial, we have also revealed remarkable effect of olukizumab treatment after 1 to 3 months of treatment in local population. Reduction of disease activity was based on DAS28 ESR dynamics. In the end, I want to show some slides, the pictures from our midterm symposium, which we hold in end of April this year in Almaty city. You see the pictures from the opening ceremony. There faces as Atik Haq. It's famous, very famous person, Nazrul Islam and Ved Chaturvedi in this group. This is officially closing ceremony, was it? And some picture, unofficially, pictures from unofficially party. As you see that Professor Haq and me are close, and Nazrul in front of us, and Ved Chaturvedi and the person Suleiman from Pakistan, and colleagues from other Asian countries, and the right picture there, Wolf, you see, in the front, the tall guy is Professor Budgereit from Germany. He is like Wolf in Almaty, and other persons from other countries, such as from Janguli from Peking, and Carlos, the president-elect of the Pan American Anti-Rheumatic League. So thank you very much for your attention.
Thanks, Professor Galimzan, for excellent deliberation and sharing the data on olukizumab. Now the floor is open for Q&A. If you do have any question, please, you can ask to the speakers.
Thank you, Dr. Ziaul Haidar, for a very informative session. I have one question. Hypersensitivity, CRP, is considered as cardiac inflammatory marker. It can predict future cardiac events. Nowadays, it is also considered as inflammatory biomarker in the practice of rheumatology. So, do you think hypersensitivity CRP has superiority over than CRP in terms of cardiac events in rheumatological disease?
Thank you. Thank you very much. Yes, I think so.
Did you get the answer? Any more question?
So Dr. Jia, nowadays the recommendation is like if anyone is already having cardiac events and after 55 years in the, the Western world, so and without any even cardiac events after 65 years, so they are not recommending. So what we can do here in Bangladesh, what is your impression? Do you have any suggestion? Because, we are in real problem if we want to follow these. The only hope we have, this kind of JAK inhibitors, we can put our patients to control the inflammation. And after 55 years, if we cannot, so, and what you are doing in your practice too, I just wonder. Okay.
Thank you, sir. Actually, in our country, this part is neglected. During management of our patient, we ignore this side. I have shown my presentation that there are several factors in rheumatoid arthritis. There are increased risk of cardiovascular diseases. So we should keep in mind only management of rheumatoid arthritis is not important. As we should keep in mind what are the risks of cardiovascular risk. And I have shown that we have to calculate this risk, as we have to assess this risk. Even I have shown that even disease control service, but even there is some risk. Considering age is also a risk factor, and hypertension, CRP, and even if we measure lipid profile also show lower limit. So to calculate actual risk, we must assess the risk factor by any validated tools, and we should recommend statin if required. Thank you, sir. JAK inhibitor, sir.
Yes, we do not have any alternatives. That's I wonder when we encounter patients, for example, after 65 years, one has come to us 66, 68 years with rheumatoid arthritis, and definitely we are putting statin, etc., etc. But if we follow the Western recommendation, like according to their recommendation, nowadays if you look at the literatures, larger bodies, they are telling not to put the patients on tofacitinib after 65 years. So in that case, we have to customize, is not it? Otherwise,
of course, sir.
The practical issue.
Of course, sir. Of course. But our countries, we know there are low socio-economic conditions. Most of our patients cannot afford biologics. So we have to prescribe these medications. We have to prescribe, and we have to reassess regularly, sir.
Thank you. Thank you.
I have a question.
Okay.
Thank you, Galinjian, for your excellent deliberation. My question is, what about your experience in case of olokizumab over tocilizumab in case of patients with adult onset of disease with pulmonary involvement? Should I say again?
Yeah.
What is your experience regarding olokizumab over tocilizumab in case of patients with adult onset of disease with pulmonary involvement, that is pleuritis or interstitial lung disease along with adult onset of disease? Your experience, okay?
in case of with a patient with rheumatoid arthritis, comparing in my country, we have experienced both together, tocilizumab, including in our reimbursement program, we are giving free of charge to the patient prescribing. And olokizumab we just started to use within, as you see, several months only, 2-3 months. Actually, the effectiveness is the same, and according of the lung involvement as well. But the convenience, I can't say that the olokizumab could be much better than tocilizumab, but the usage, I mean, once in 2 weeks, it's or once in 4 weeks is more convenient. And in my presentation, I mentioned also about it. But actually, there are not so much difference.
Okay, thank you very much.
Yeah. Can I please? Yeah, Galim, in your presentation, you have shown that's the one striking observation. In a period of time of using tocilizumab, so the end of the day, your concentration goes down in the serum. And on the other hand, olokizumab, it goes up. Can you please think of that? I'm thinking is that, can you translate these changes make olokizumab more effective than the tocilizumab while we use this one for the long time?
Yeah, it's actually, we have to prove it, yeah, according of the experience. Unfortunately, I don't have much experience for the olokizumab. Firstly, when we start to use it, I was a little bit negative, but within this, I mean, experience, and I'm sure the effectiveness, of course, good. And as I mentioned, the one patient switched another biologic. The patient used before, some times ago, tocilizumab. It was effective to her in other countries. And when we prescribed olokizumab, she was negative for that. That's why we switched to the tocilizumab. But according of the effectiveness, I see the good results. And as you, Nazrul, mentioned about that, of course, this is a very interesting point.
Thank you. Now let's hear from the chairpersons. First, may I request Professor Ismail Patorisa to say a few words, a comment on these two topics.
First of all, I thank the Bangladesh Rheumatological Society for inviting me and to chair this session. The first speaker, that is Dr. Ziaul Haidar, actually excellently he described about the comorbidities which is associated with rheumatoid arthritis, which we usually ignore in assessing these comorbidities, especially the cardiovascular morbidities and mortalities. He nicely described about the cardiovascular risk increases 1.5 times more in patients with rheumatoid arthritis. So we should address this, and during the treatment protocol, actually, we are using the DMRs and other JAK inhibitors and also the biologics. And when we are treating these cases, that is, we should be very careful about the JAK inhibitor. So the rheumatologist and the internist should be very careful when they are treating a patient with rheumatoid arthritis with these cardiovascular, cerebrovascular diseases. We should assess the cardiovascular risks and we should treat accordingly. Not only that is the inflammatory arthritis, but also the other risks we should address. So thank you, Dr. Ziaul Haidar. And the second speaker, the guest speaker from the Kazakhstan, that is Galim, he have actually very nicely described about the IL-6 inhibitor, about the olokizumab, which we are not actually yet, we are not using these drugs and we have little experience. During the COVID era, we have used the tocilizumab during the cytokine storm, and those patients who have the pulmonary involvement. And we have seen that this patient, actually many patients have saved with the use of tocilizumab. But he has nicely described, though this is not yet FDA approved, but in some countries of Russia, Kazakhstan and other, that is Russian territories, they are using it and they are actually showing good results in patients with rheumatoid arthritis. Even those patients who are using this IL-6 inhibitor with methotrexate, that is also they are showing the very good results. So our future rheumatologists can do this study in our country, and we should whether we include in our national guideline, that will be the future decision can be taken whether this is effective. We usually traditionally we use that is chemical DMRs. That methotrexate is very popular, as well as sulfasalazine, hydroxychloroquine, and the TNF alpha inhibitor. But this is a new era in the management of the rheumatoid arthritis, especially those patients who have the renal impairment, as well as those who have the lung involvement. So this can also be considered. So thank you, Dr. Gelivejan, for coming to Bangladesh and actually enlightened us with this new drug. Thank you very much.
Thank you, sir, for your nice comment. Now, may I ask Professor Manirali sir to say a few words?
Thank you, Moderator Dr. Mahabub. It's my honor and privilege to appear before you and be able to say something. And especially I'm privileged when I'm sharing this dais with someone like Professor Ismail sir. We had two speakers. First one, Dr. Zia, sitting beside me. He had a brilliant presentation. It was a colorful presentation, very vivid slides. He had made a wholehearted attempt to keep an eye on hearts of rheumatoid arthritis patients. He said that rheumatoid arthritis patients suffer more cardiac diseases than peer population, like 50% increased risk of cardiac diseases. So hurting the heart comes in many ways in rheumatoid patients, like cytokines, like vasculitis, coronary vasculitis, like steroids, NSAIDs, JAK inhibitors, and others. Jia properly mentioned those areas. Jia mentioned about BMI and lipid paradox. Jia mentioned about different risk assessment tools like QRisk and others. He also mentioned that currently AI is not going to help us that much. It is in the development phase. There are some drugs also that are actually helping the heart in rheumatoid patients, like MTX, like anti-TNF drugs, and the least used drug like hydroxychloroquine. It may not be that potent a drug for rheumatoid arthritis, but it can help our heart. And special concern about JAK inhibitors, tofacitinib and baricitinib. And I am a rather critic of BRS guideline when I saw that when MTX failed in a patient with adverse prognostic factor, BRS advocates jumping on to tofacitinib and baricitinib or like that. But even in APLAR, you see, they have proposed double or triple combination. So, and I have seen many patients now having tuberculosis using these JAK inhibitors. So, do you have that much luxury of doing that quantiferon TB gold or like that? So I strongly believe that there should be some changes in Bangladesh Rheumatology guideline about just jumping onto tofacitinib after methotrexate failure, rather than opting double or triple combination. I'm sorry, I don't know whether I should mention it now. So Jia had mentioned other things very nicely, and he have some advocated some other things like moderation of steroids and NSAIDs and like that. And our second speaker, sir, I am afraid I may not be able to correctly utter your name, Galim Zan, sir. So I hope you are having a very nice time in Bangladesh. You talked about novel interleukin-6 inhibitors like olokizumab in patients with resistant RA, and other older IL-6 inhibitors like tocilizumab is very familiar to us. We are using it. All interleukin-6 inhibitors have some inherent benefits, like they are renal friendly, and they have not potent immunosuppressive actions like other anti-TNF drugs, and they do not increase cardiovascular risk also, although it causes dyslipidemia. And about off-label indications, during COVID pandemic, the famous cytokine storm was addressed by tocilizumab, and IL-6 have, you mentioned, other advantages that like it can be used in JIA-resistant Takashio's arthritis and giant cell arthritis. It can be used in systemic sclerosis related ILDs also. Do you know in Bengali, alaukik means something unnatural or supernatural. So let's hope something supernatural will be unveiled in the form of olokizumab in coming days. So thank you everybody for patient hearing. Thank you Mr. Moderator, thank you Ismail sir, thank you Dr. Zia, and thank you Galimzan sir. Thank you everybody.
Thank you sir. Now it's time to hand over the memento to the speakers. May I request chairpersons to hand over memento to our speakers first. I request to hand over the memento to our second speaker, the speaker from abroad, Professor Galimzan. Next one, Dr. Muhammad Ziaul Haidar. He will take memento from the chairperson. So with this, I conclude this session. Thank you all for active participation and patient hearing. Thank you very much.
Dear participants, let's have a tea break. And after the tea break is only 15 minutes. And then the session of spondyloarthritis will begin. Just 15 minutes tea break. Thank you.
You are watching Raj TV, Jagorone, Bangladesh.